So for those who don't know me, my name is Michelle. I'm one of the EMIM4. This is the title, Happy or Not, Here I Come, courtesy of Maya Seegers. So special thanks to Doctors Morley, Berland, and Wiener, and Dr. Seegers for the title. So we'll first kind of go through a case, go through differentials, talk about mechanism of the drug involved, why these individuals are on this medication, the toxicity management, and talk back to the case. Okay, so this is a case that I found from literature from the 2021 MPDS data. So it goes as a 29-year-old female who comes in per EMS. They found empty bottles next to her, and she's coming in with slurred speech. Once she arrived to the ER, she was seizing. So what do you guys want to know about this case? I will tell you about that later, but for now, what questions? Vitals, perfect. So these are her vitals. So she's just tachycardic, but afebrile, saturating 93% on room air. So what do you guys want to do next? Skin exam. In terms of physical exam, nothing was actually written in the literature, but overtly they were just, before she came in, just some notes that she was slurring, but otherwise, what would you do because this patient's actively seizing? Yeah, perfect. Yes. So I think her finger stick was normal when she came in, right? You got to do ABCs, right? Airway, breathing, circulation. So is her airway protected, breathing, circulation, and all that jazz? So first thing they did was give a benzo, right? So they, at the time in 2021, there was no lorazepam shortage. So they gave lorazepam, but in, I guess, this day and era, with that shortage, you can get midazolam. If they don't have IV, midazolam is also great. She gets that, she stops seizing, and you're able to kind of do your primary survey, right? So go through ABCs, go through physical exam and whatnot. Um, 30 minutes later, actually, after the initial lorazepam was given, she developed another seizure. So what would you guys do next? Yeah, more doses of benzos, right? So that, because you want to stop her from seizing, right? I don't think she ever like returned to baseline, but in the case, they were, because she was unable to protect her airway, she got intubated with etomidate and sucks, and then was sedated with propofol and fentanyl. But slowly her labs are trickling back, and these are her blood work results. So what do you guys want to comment on it? I know everyone has a face that is, it's pretty bad, right? So there was no respiratory rate documented, unfortunately, but I'm assuming she was not tachypnic on the vent. They're already intubated. They did not document it in this MPDS case, unfortunately. But what can you guys comment about the blood work? What do you see that stands out to you guys? Correct. Anything else? Long QT. Any? Yeah. I believe bicarb does get calculated on an ABG. I think the BMP is probably more accurate depiction, but this was the data that was given on the MPDS report. So something else to mention is that her QTC, well, someone mentioned her QC, but she's also tachycardic and she has a lactate of 18. So you get a little bit more information. So she, in terms of her past medical illness, she has a history of depression, anxiety, and panic attacks, as well as PTSD. Medications that she was taking at home was bupropion, extended release, as well as hyrosalamine, which is something that's an antispasmodic. I can't pronounce medication sometimes, but has anticholinergic activity, as well as birth control. So EMS report did say that she did ingest 60 pills of the bupropion, actually. So in terms of that, what differentials would you typically have for anyone who is seizing, found next to bottles or one out? Like what are some thoughts for like drug-induced seizures or any sort of seizures? Any differentials, guys? Sorry if this is causing your eyes to hurt. Yeah. INH toxicity, anything else that anyone could think of? It could be even withdrawal. So we were talking about alcohol withdrawals before, right? So alcohol withdrawal seizures, bupropion, which was mentioned in Jedley's talk, but also lithium, lidocaine, sympathomimetics, insulin. So if they're injecting organophosphate toxicity, as well as TCAs, and then a couple of others like methylxanthine. So if you consume a huge amount of caffeine, like huge, to a point where like you're actively overdosing, which we probably won't ever get to, you can seize too, as well as amphetamines, anti-epileptics, cocaine, clozapine, and benzo withdrawal. So those are a couple of things. So I guess, yeah. But also like other differentials could be like brain lesions, malignancy, primary seizure disorders, right? So I guess let's talk about what bupropion is. I think Jedley had a nice diagram before about in terms of mechanism of action. It's a norepinephrine and dopamine transporter inhibitor. So it is typically absorbed by the GI system and renally and urinary excreted. So it is metabolized by the CYP2B6 enzyme, and it produces active metabolites, the more well-known active metabolites that has all these active metabolites have longer half-lives, but the more well-known is hydroxy bupropion. It is similar in terms of bupropion to amphetamines, which is the chemical structure to the right side. So if you do a urine tox screen, it can be falsely positive. So bupropion comes in many different forms. There's an immediate release, sustained release, as well as an extended release. So they come in different concentrations. Initially, when bupropion was released and in the general public, there was high seizure, I guess, side effects with it. So they actually withdrew it and re-released the medication with a cap of 450 milligrams as the max dose per day. It had decreased incidence of seizures to like 0.5%. Typically, the peak concentration for this medication is 2 hours for the immediate release, 3 hours for extended sustained release, and 5 hours for extended release. It could take up to 2 weeks to reach a therapeutic event. Duration of action is typically 1 to 2 days. The typical indications, at least approved by the FDA, is for depression, for smoking cessation, as well as seasonal affect disorder. However, there are a couple of off-label uses, like for ADHD, for obesity, as well as for I guess sexual dysfunction induced by other antidepressants, as well as depression associated with bipolar. So because so many people are on these, or there's so many different indications, and it's relatively weight neutral, doesn't have the side effect of sexual dysfunction, it's a medication that's more commonly prescribed these days. So this was a diagram that I got, chart I got from the NPDS data from 2021, because there's now higher prevalence and I guess prescription of bupropion due to like many of the benefits. As you can see, there's more and more reported severe outcomes from bupropion compared to things like TCAs and lithium. So typically TCAs do have a higher lethality as well as lithium. However, given the increased prevalence of this medication and people using it for many different reasons, such as depression, for sexual, that you don't need to worry about the sexual dysfunction side effects, or for like smoking cessation, it is occurring more often. So in the 2021 NPDS data, approximately 133 fatalities were reported for antidepressants, 32 of which were bupropion related, the regular bupropion, and 24, which is the extended release of bupropion. In 2023 data, there's been 114 reported fatalities associated with antidepressants, 35 of which were bupropion, 14 were extended release bupropion. So doing the math, it's about like 40 something percent of the reported antidepressant fatalities were associated with bupropion. So this is a great diagram from EM-Crit. So it's a great blog. If you guys have time, you can review it. They have great, I guess, descriptions of going through things like bupropion toxicity, like alcohol withdrawals and all this jazz. But this is specifically from the bupropion toxicity page. So toxic levels can be considered even as small as 600 milligrams. So if you accidentally like take double of your dose of bupropion for the day because you're like, oh, maybe I didn't take the dose and take double of it, it can be considered a toxic level. Most people don't have really any effects from taking the medication. I think according to a 2014 data set, it was like 0.5% of bupropion overdoses were associated with fatalities, but seizures are common with doses greater than 2.5 grams, and serious toxicities can be expected in over 6 grams, and fatalities associated with over 9 grams. So it has a very narrow therapeutic dosing, so it's something to keep in mind. This is an article from 2009 where they kind of did an observation study from over 3 years from multi-poison controlled data sets for high doses. So what their definition of high dose ingestions were greater than equal to 4 mg per kg in children or greater than equal to 600 milligrams in adults. So in approximately 21% of the 100 and I believe it was 117 or 130 something people that they included in this observational data. There are 21% had seizure activity in the immediate release formulation, and 11% of those individuals had it with a sustained release formulation. So their recommendations was to actually observe individuals for at least 24 hours due to concerns for delayed seizures. I think they only had really one case that was reported that had a seizure at the 24-hour mark. Something else to note from the previous, I guess, chart, I'll go back, is that, normally people can be okay, but they can develop things like tachycardia, delirium, agitation, and whatnot, seizures. And then when it does get to a high enough dose, cardiac toxicity. So the cardiac toxicity really is about bupropion kind of inhibiting and interfering with gap junctions. So people can start bicarbonate drips for these patients. However, and that might be to treat other etiologies, but bicarbonate drips don't really treat bupropion toxicity because it's not targeting like the sodium channels, it's targeting the gap junctions. So this was a paper that was published recently in 2024 or 2023, where they were like, maybe there's going to be some hypothetical drugs in the future that kind of work on the gap junctions to help with treating toxicity. One of the mainstays for management, although it comes with a lot of caveats, are things like activated charcoal. So activated charcoal kind of helps with decreasing absorption, as well as I think there has been studies where you give activated charcoal after and measure certain drugs. I believe it was methylxanthines in the past, and it showed to have lowered levels. But something to note that we can give activated charcoal to these patients if it's like an hour after ingestion, but keep in mind that these patients have a high risk of seizures and aspiration as a result. So I'll be very cautious with giving things like activated charcoal in these patients. Something else to talk about would be things like whole bowel irrigation. So in EM-CRIT, they kind of recommended, obviously, if the patient is awake and there is an aspiration that does exist, maybe not do the whole bowel irrigation. Typically, the recommendation for whole bowel irrigation might be after they get intubated, just because they already have an airway, their airway is already protected. In this. So according to the American Academy for clinical toxicology, they do recommend basically whole bowel irrigation for things that are sustained release or enterocoded 2 hours after ingestion. Something to keep in mind is that if you do whole bowel irrigation, it decreases the efficacy of things like activated charcoal, but it is particularly useful for things like iron ingestions, lithium, potassium, as well as people who are body packers. So they are maybe transporting drugs. Kind of how to do whole bowel irrigation is you kind of just place an NG tube or OG tube into the individual and feed them a lot of, go lightly until their stool or their effluent is clear. Another recommendation for treatment for anyone with bupropion toxicity would be things like ECMO and intralipid emulsion. So kind of to generally talk about intravenous lipid emulsion. It is a rescue therapy. It has a lot of side effects. Bupropion is a very lipophilic drug. The thought process behind doing intravenous lipid emulsion is that, they will have the lipids kind of do a lipid shuttle where they'll bring it to the liver to get metabolized. Obviously, intravenous lipid emulsion has a lot of caveats. People can be dyspneic, they can develop things like acute pancreatitis, develop hypercoagulability, and have transaminitis, as well as develop things like lipid embolus and AKIs, cardiac arrest, lung injury, and increased risk for infection. People who have done lipid emulsion therapy in the past, it's really with mixed results because it is a rescue therapy. If you do intravenous lipid emulsion, it can interfere with ECMO. So if you're planning to transfer a person to ECMO, please do not give this medication. There have been multiple reported cases, at least, of patients who have been placed on ECMO with kind of great results. A lot of times it's just waiting for the drug to kind of metabolize, and so you kind of provide them support in the meantime. From what I heard when I did my tox rotation, a lot of ECMO centers do enjoy having patients who are there for toxicities just because at least there's an endpoint for these individuals. So going back to our case, so she was intubated, went to NICU, had a continuous EEG, which showed severe background slowing with intermittent generalized electrographic seizures associated with full body myoclonus. So at the time, despite getting fluids, and everything, she was still persistently tachycardic, and was started on pressors after she was also continuously hypotensive. She did receive IV sodium bicarb. Her numbers got better. So like she had a pH of like 6.96 and a lactate of 18. It did improve. But at the time she developed another seizure and basically had the intravenous lipid emulsion started and went into cardiac arrest and basically expired within 24 hours. So the autopsy report showed bupropion levels of 665 nanograms per milliliter, as well as hydroxybupropion of 1,974. It's likely that she ingested in a suicide attempt, according to the postmortem reports. So I guess a few takeaways would be most of these patients do fine overall, but obviously monitor them for a little bit. It's supportive care for the most part. So benzos for seizures, and benzos for seizures until like they get on a propofol drip, which you can treat. You can consider whole activated charcoal, but it is a risky procedure given the risk for aspiration. Whole bowel irrigation can be considered if they're intubated, so that way you can try to clear up the tablets because it can cause ileus, which then can increase absorption in the GI system. Sodium bicarb is not effective, at least when treating for the cardiac toxicity, but it is something you can use. And then transfer to an ECMO center if you know that this patient is critically ill, developing things like cardiac toxicity. And if there's no ECMO center nearby, they're not willing to take it, then intravenous lipid emulsion as the last ditch effort. And don't forget, please call poison control. They benefit a lot from, they can help you, or actually call Dr. Weiner too. Dr. Weiner, Dr. Berlin, the tox group chat, but poison control is a great resource. So if you have questions, you're like, this patient C was found up next to a bunch of medications, they can help you come up with differentials and help guide your management of these patients. So these are my sources. Any questions?